On this episode of the ASC Podcast with John Goehle, we discuss the latest news in the ASC industry, review issues with the 2025 Medicare Quality Reporting Measures, discuss the future of staff shortages, and review recent litigation. In our focus segment, we will discuss life safety with Ruben Garcia, a life safety surveyor with AAAHC and a life safety consultant.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsor, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 229 of the ASC Podcast with John Goehle for September 8th, 2024, recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of the recording. As such, it's important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by the relevant regulatory bodies. And joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry and is a sought-after speaker on regulatory accreditation and finance issues.
So, Sue, we're recording this just after Labor Day, and the summer is ending. We're going to be closing up the pool soon.
Yep.
The nice thing is we have all that fall foliage and the fall food, vegetables, so we're enjoying that. But I hope everybody had a great summer and ready to head into conference season, it seems, doesn't it?
Yeah, it really does. And I do love the fall. We went for a walk yesterday, and it was so nice and cool and breezy, and so kind of ready for it.
Well, hopefully everybody is enjoying the fall weather now. And, we just finished our semi-annual retreat. We hold it here in our home, actually in upstate New York, in Spencerport, New York. And we had about 5 people joining us remotely, and I think about 15 or 16 people here in person, all from Ambulatory Healthcare Strategies, and some of them are some of the staff of the podcast also. But it's always a great opportunity to bring everybody together twice a year, since we are a virtual company. Boy, it was pretty intensive, wasn't it? We had a lot of interesting conversations going on and a lot of things happening. As we've talked about before, we take the semi-annual retreat as an opportunity to review recent citations in our various centers, the surveyors on the team. We have about 5 surveyors, kind of discuss some of the recent experiences in doing surveys. And we always take those opportunities to learn something that, pretty much following, what we preach about, which is quality improvement. So I want to thank all of our staff for taking the time to visit with us here. One unusual thing is we did not actually record a podcast with them this time. We didn't have the time for that, and we just can't do that every single time. But we will probably do that. Again, I think we're probably getting together in the winter time, sometime in the winter time or early
beginning
next
of
year.
The year. Yep.
Yeah. I do want a reminder that we did announce the 2024 Multi-State Virtual Conference, which is going to be November 14th and 15th. Like last year's very successful 2023 virtual conference, it's a great opportunity opportunity to get 2 full days of valuable insights from some of the nation's leading ASC experts in the area of infection control, life safety, human resources, finance, and survey preparedness, and actually much more than that. And if you are CASC or CAPE certificant, the program offers 16 AEUs and 4 IPCHs. And Sue, it's a great time to get them right in November, just before the end of the year.
And that's a good amount. So
that is. It's actually more than some state association meetings and even, similar to what ASCA provides. So it's a great opportunity to pick up a lot of credits right away. And if you are a member of some of the state associations, there are 8 state associations that are sponsoring it, then you get access to it for free. So New York, New Jersey, Massachusetts, Virginia, Texas, Pennsylvania, Oregon, and Colorado. As of the recording of this, we're hopefully going to have a few more states joining us very soon. So if you're a member of any of those states, again, New York, New Jersey, Massachusetts, Virginia, Texas, Pennsylvania, Oregon, and Colorado, all of those states are co-sponsoring the virtual multi-state conference, and as a member, if you are a member of that state association, you get access for free. And if you are a member of our patron program or our Premium Access program, you also get access to it for free. So for more information, go to ASC-Central.com and follow the links for the educational programs. And if you are a leader of a state association, email us at info@ascpodcast.com to sign up today. It is free for your state association. You don't have to pay anything to offer this to your association members. So during my Illinois visit a couple weeks ago, I had an interesting conversation with some of my colleagues there about the ASC Medicare Quality Reporting. You and I talked about some of the recommended changes or the proposed changes in 2025 for 2025 and how they didn't really seem to fit in with the ASC world. They seem to have been cut and pasted or copied and pasted from the hospital. And, let's make it clear. We want to report quality data to prove the high quality of care that we render. But the Medicare Quality Reporting System doesn't seem to be filling that role, though. I'm kind of disappointed about where it's heading. I think, again, we want to prove quality, but some of the measures that they've been coming up with don't really seem to make a lot of sense. And it's starting to veer away from the quality measures into some unknown territory. For example, the COVID-19 vaccination reporting requirements and the new proposed measure in health equity for 2025 and the 2 additional health equity measures which would impose some significant burdens in the future seem to really have nothing to do with quality care in an ASC. And they seem to have, as I said, been copied and pasted from the hospital regulations without really any changes into the ASC regulations, without recognizing that ASCs don't provide any primary care and don't have the staff of social workers to provide assistance to patients, nor enough information about the patient to really provide comprehensive assistance like hospital or primary care doctor could provide.
Yeah, and a big point about this is that anything that takes up time away from giving quality care to patients and uses staff in this, environment of low staffing is just, it can be actually harmful, not just that it's an annoyance to have to do these things. It's going to pull you away from things that are really going to improve the quality of care.
Well, and one of the examples I give is, let's say that in the pre-op area, you're questioning a patient and you ask them about access to high-quality food or access to food and water. And if they come back and say, no, I'm in a food desert, for example, in the city, and I have a hard time getting, food or for my family. I guess the question is, what are we going to do about it? Our the nurses in pre-op, for example, don't have access to that information. We don't have an ongoing relationship with social services, nor has it really ever been a part of what we do because we don't, we're not involved in primary care. So I really do question the value of it. And, there's other measures like the proposed cataracts improvement in patients' visual function within 90 days following cataract surgery, which would place a huge burden on ASCs, requiring ASCs to call all cataract patients 90 days after their surgery to ask them a series of questions related to their visual acuity after the surgery. Right now, it's a voluntary measure, but they are proposing in the future to make it a required measure. And it seems to me like for cataract providers, surgery centers that do cataracts, I could imagine it might actually require the addition of one more person. And this really is, in my view, maybe I'm wrong, but the responsibility of the surgeon who did the procedure himself. I'm sure that they are following up in some way to make sure that that's done. But the requirement would put that burden on the surgery center. Now, I do want to point something out, and this is one of the discussions we had during the Illinois Association meeting. Remember that ASCs that have fewer than 240 Medicare claims, that would be primary plus secondary payer, per year during a reporting period for a payment determination year would not be required to participate in the Medicare Quality Reporting Program for the subsequent reporting period. Now, it's important to note that those 240 Medicare claims have to be traditional fee-for-service cases, so they wouldn't include any HMOs, Medicare HMOs, et cetera. And so the question that we had when we were over meals, for example, is in the future, if you do more than 240 cases, is the penalty for not reporting these Medicare quality reporting measures is a reduction of 2% in your Medicare fee-for-service reimbursement rate. And
it won't go up by 2%.
It won't go up right. It'll go up 2% less than whatever they would have gotten that increase. And seriously, the question is, since that would probably be a very low number of cases and a decreasing number as more and more Medicare patients go into HMO programs, whether that penalty is really worth the extra effort that goes into it. So, and I guess the big example of this is that COVID-19 measure. That COVID-19 measure requires quarterly reporting. It's a lot of work, for the staff to keep that reporting up. And of course, all they're doing is asking if somebody has had the COVID vaccine and how up to date they are with the boosters. And it just seems to be an awful lot of burden for very little value. The ultimate question, though, is if a lot of centers stop participating, will that result in the media trying to paint the industry in poor light, even though we know that many of these measures have little to do with the quality of care in our center? So I just thought that was kind of an interesting discussion, and I put it out there as one of those discussion points that we will probably be having in the future as the Medicare Quality Reporting Program veers more and more away from true measures that would be useful to show the high quality of care that we provide. With that, Sue, I'm going to turn it over to you for some news.
This was an awful bit of news. A doctor in Florida allegedly removed his patient's liver instead of his spleen. The patient was complaining of left-sided pain, and the hospital noted some issues with the spleen upon imaging. The surgeon told the family after the operation that the spleen was so badly diseased that it was 4 times larger than the normal spleen and had migrated to the other side of the body. Basically, it was the liver, which would be on the opposite side of the body and would be larger. The reason that we wanted to talk about this, though, is that the same surgeon was accused of wrong site surgery in 2023 when he removed part of a patient's pancreas instead of resecting the adrenal gland, as was planned. That first case was settled privately. This just underscores the importance of taking any mistakes seriously and performing and documenting a thorough RCA.
Yeah, I find 2 things here is, first of all, this doctor is probably going to, now this was in a hospital. It's important that we note this was in a hospital. And, a couple things come to mind from this is, first of all, when this guy comes up for re-credentialing in the future, I certainly hope that this will be taken into consideration by any surgery center or hospital because, having 2 incidents, of course, having 1 incident is bad enough, but to have a second incident, this is one of the reasons we have credentialing processes that we privilege, people to our centers. And, the podcast Dr. Death talks about this very thing also, is that we need to make sure we take that process seriously in case this type of an individual shows up on your doorstep. The second part, and I actually bounce it back to you a little bit, Sue, is would somebody else in the room perhaps have noticed that the doctor was removing the wrong body part? I don't know the answer to that one, and maybe we don't have enough information. No,
and I think and this was a discussion we had among the staff too, because it was done at least partially laparoscopically.
Yeah.
So honestly, I don't know how much the other people in the room see and how much they do. It seems like just being on the opposite side of the body and it just seems like somebody would, but I guess I don't know. Like you said, we don't really have enough details to see.
Well, and I guess the reason I bring that up is that we all need to be paying attention during these procedures. We've been watching out for these things. Yeah. Anything can happen. Wrong site surgery is not as uncommon as we would perhaps hope it would be.
I think this is a particularly bizarre one, though.
Well, and the patient did not survive.
No,
too. That's
important
to know.
On the table.
So, so I mean, again, showing the importance of, making sure that, we keep close eye about what's going on during the procedure, and also, managing your credentialing process. And as you talked about the RCAs, when you do an RCA, you need to do a very thorough investigation. Hopefully after this event, the hospital had done a thorough RCA to look at all of the factors that led to the wrong body part being removed, because it's not just the fact that the doctor, wasn't careful here. There's other factors that I would think would be involved, or perhaps would be involved. But again, you want to have an RCA to look into that root cause analysis for those that are not familiar with that term.
And I saw an article in Becker's Hospital Review about the upcoming deficits and surplus of healthcare workers expected by 2028. This came from Mercer, and they had predicted a nationwide shortage of 100,000 healthcare workers nationwide by 2028. But it's really going to vary widely among different states. I was surprised at the difference. So 5 states with the greatest projected surplus of workers will be California, Pennsylvania, Texas, Minnesota, and Washington. Anywhere from California's 16,000 something, and Washington was 8,000 and something. And the 5 states with the greatest projected deficit of workers, New York, where we are, so that was kind of bad. And that's
a very high number.
Deficit of 61,000. Then New Jersey, so right nearby, Tennessee, Massachusetts, and Georgia. And we're also putting the link to the Mercer's interactive map showing projected shortages and surpluses for different categories of healthcare workers, including RNs, physicians, and nursing assistants. So you can look at, because they aren't always the same.
Right.
It's not always across the board.
Yeah.
Yeah, so it shows a bunch of different states. So
this is fascinating to me because, again, the deficits are larger than the surpluses in general. And a lot of though there isn't a lot of trending, like Pennsylvania is right back to New York, and New York has a huge deficit. Now we know that there's a giant outflow of individuals from New York to other states, but California's got a surplus, and they have that same problem of people leaving. So this is just fascinating information. So as Sue said, we'll provide a link to it so that you can kind of look at what's going on in your state and see how that might affect you. And again, we really want to kind of emphasize how important it is, as part of your strategic plan to keep a close eye on what's going on in the future so that you can be prepared for this. Perhaps, working closely with educational programs like Surge Tech programs, nursing programs, to see if you can, get people exposed to the surgery center during their training so that they'll consider it in their future.
And according to Press Ganey research, patient satisfaction scores for ASCs and medical practices have reached a 5-year high. Hospital scores are improving, but they haven't completely recovered to pre-pandemic levels yet. In some areas and care settings, there are lower ratings by underrepresented populations, especially in the areas of empathy and care personalization. So that's an area that centers should be aware of and look to improve. Younger patients in that 18 to 24 range tend to give lower ratings. And they also noted that scores for unplanned admissions are usually much lower than planned procedures. Not real surprising, but although obviously you can't control that, Press Ganey suggested that may be largely due to the patient feeling unprepared when it's an unplanned one, and they stress the importance of good communication and transparency throughout the process. So whether it's planned or unplanned, just make sure you're really kind of walking your patient through, making sure that they really know what to expect, and your discharge instructions and all of that, so that, they feel a bit more comfortable, because that really helps.
I find this information fascinating in light of what we were just talking about, the Medicare Quality Reporting, because here is great. I mean, first of all, Press Ganey is famous for doing, real scientifically based studies. This information is an aggregate of a lot of information across the nation. And it just seems to me that this, actual patient satisfaction survey results, which include a discussion as to how they were treated as well as their outcomes, seems to be a much better way of determining quality. And it's not a surprise to me that that surgery centers are showing and medical practices are showing at a 5-year high, and then unfortunately hospital scores are though it's good that they're improving, but they're falling behind what happens in surgery centers. That's why we're here. We hope to give patients a better patient experience, and let's not forget the importance of always looking at this data very critically to determine how we might be able to improve. Even if we're doing great, even if we have a 98% satisfaction rate, we still should be looking at that data to see how we can get even higher than that.
And from HIDA clips, CNBC News talked about the potential longshoremen's strike involving workers at U.S. East Coast and Gulf Coast ports. This has been threatened to happen on October 1st. Here are some key points from the CNBC article. U.S. East Coast and Gulf Coast ports handle 43% of all U.S. imports. However, companies have been moving shipping containers to the West Coast due to the concerns for this strike, so that may mitigate that a little bit. The discussions between the labor union and ports management have been unsuccessful, and many ports are beginning to use automation, which has become a really big issue in the negotiations, as it would impact the number of jobs open for workers, as many might be replaced by the automation. Union leaders have described the negotiation positions as very, very far apart and said they are at a contract impasse. So it kind of sounds like it may end up happening. So just to be aware.
And Sue, this came from HIDA. I did want to shout out to HIDA. HIDA stands for the Health Industry Distributors Association. And I worked very closely with HIDA. Actually, I'll be going to their conference on Wednesday and Thursday, I believe, of this week to speak to the distributors about how to work with surgery centers. And HIDA has a lot of great information, especially with regard to the supply chain. So I keep a very close eye on that, and that's one of the things that we've quoted HIDA in the past also. So keep an eye out for that, and again, make sure your inventory levels are not getting too low.
And following up on this, Outpatient Surgery Magazine had an article from August written by Dr. Thomas W. Durek, and it gave some suggestions for dealing with supply chain shortages, including working with multiple suppliers and GPOs or group purchasing organizations. A lot of people do have are involved in that. If you could have more contacts, that definitely helps. And plan ahead to keep items in stock that you use frequently. And of course, this is going to depend on the size of your center and your storage. I mean, a lot of places really can't keep too much. Right. But keep up to date with the federal websites that can warn you of medication shortages as they come up, so you can really plan which items you do need to have in stock ahead of time. And consider checking the secondary market for those items that you don't need many of. There might be another center who overbought or just is also only uses a few of a certain thing, and they get them maybe in a pack of 10, and they're nearing the expiration date. Sometimes you can kind of join with them, and you can each get what you need without overbuying and losing things to expirations. And some information about COVID. The CDC is now calling SARS-CoV-2 endemic instead of pandemic. It just means it's likely here to stay, which I think we've all realized, but is no longer spreading out of control or stressing the healthcare system at this time. This, of course, doesn't mean that it's not a concern, so it seems like kind of a fine line to me where they call it that, but we thought it was a good time to remind people to reassess their policies. You might want to have a general emerging infectious disease policy rather than to be specifically a policy about COVID.
Yeah, again, we also run the danger of thinking that COVID is not that dangerous anymore. Yeah. But we have to think of kind of the way we think about the flu. The flu is a very dangerous situation. If not properly handled or if you're not monitoring it closely. So, and we have migrated all of our policies really in this area, an infectious disease area, to what we call emerging infectious diseases. And that most surveyors are expecting to see that. I as a surveyor, really don't want to see you focusing on COVID anymore alone. I mean, it's all right to mention COVID, but really you should be talking about all emerging infectious diseases and making sure that you're monitoring all of those situations.
And I still do see articles. I don't have anything specific here, but talking about the higher risk of surgery when it's within a certain time frame of having had a serious case of COVID, and it's probably the same with the flu or a lot of those things. So it still is something that you have to think about.
So, Sue, when I was looking back on the various episodes that we've done and the topics we focused on, life safety is not one of those topics that we spend a lot of time talking about. So during the Illinois State Association meeting, I have an opportunity to visit with Ruben Garcia, a good friend of mine, and he is a AAAHC surveyor as well as a life safety consultant. And we had an opportunity to record an interview that we use as part of our special episode from Illinois. And I thought it would really be a good idea to put that interview into this podcast. So we're going to take a short break, and when we come back, we're going to talk about the regulations surrounding life safety in an ASC and then have an interview with Ruben. So let's take that short break, and we'll be right back. With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our administrator boot camp and the director of nursing boot camp, and in 2023, the business office manager boot camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central patron program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com. Or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. So for our focus segment, I thought we would discuss life safety. It's one of those areas that we don't talk a lot about during the podcast, and I thought it would be good to start off by talking about the regulations, referring back to the regulations from CMS. One thing that's important to understand when you're looking at the life safety area and the environment of care area is that the CMS regulations don't go into a lot of specificity in this area, especially for the environment of care. And in this situation, we have to refer back to NFPA 99. But let's go through the different regulations related to the environment of care and life safety. And this is in 416.44 of the conditions for coverage. And the condition states this: the ASC must have a safe and sanitary environment, properly constructed, equipped, and maintained to protect the health and safety of patients. And the interpretive guidelines for this section state the ASC must comply with requirements governing the construction and maintenance of a safe and sanitary physical plant, safety from fire, emergency equipment, and emergency personnel. And then the rest of 416.44 goes into more details. And we'll start with 416.44a, which is the standard for physical environment. And it states the following: the ASC must provide a functional and sanitary environment for the provision of surgical services. Each operating room must be designed and equipped so the types of surgery conducted can be performed in a manner that protects the lives and assures the physical safety of all individuals in the area. Now, it's important to note that there isn't a lot of detail here. It doesn't actually indicate the size of the room or what's included in the room. And there's a lot more details in the FGI guidelines. FGI stands for Facility Guidelines Institute, and they're the ones that publish the information that goes to the architects as to how healthcare organizations should be designed. Moving on to 41644A2, which states the ASC must have a separate recovery room and waiting area, which I think is kind of obvious. And then 41644B1 states, except as otherwise provided in this section, the ASC must meet the provisions applicable for ambulatory healthcare occupancies, regardless of the number of patients served, and must proceed in accordance with Life Safety Code NFPA 101. And it goes on to indicate some of the tentative interim amendments. So it's important here to note that with this statement, NFPA 101 is actually integrated into the CMS regulations. Continuing on to 2. In consideration of a recommendation by the state survey agency or accrediting organization, or at the discretion of the secretary, they may waive for periods deemed appropriate specific provisions of the Life Safety Code, which would result in unreasonable hardship upon an ASC, but only if the waiver will not adversely affect the health and safety of the patients. So this is better known as the waiver section. And note that it is really only allows for time-limited waivers in the future. And then continuing on to 3, the provisions of the Life Safety Code do not apply in a state if CMS finds that the Fire and Safety Code imposed by the state law adequately protects patients in an ASC. So again, if the state laws are more restrictive than they would be the applicable regulations. Continuing on to 4, an ASC may place alcohol-based hand rub dispensers in the facility if the dispensers are installed in a manner that adequately protects against inappropriate access. And continuing on to 5, when a sprinkler system is shut down for more than 10 hours, the ASC must, 1, evacuate the building or a portion of the building affected by the system outage until the system is back in service, or 2, establish a fire watch until the system is back in service. So this obviously implies that you need to have a fire watch policy that meets these regulatory requirements. Continuing on to 6. Beginning July 5th, 2017, an ASC must be in compliance with Chapter 21.3.2.1 of the Life Safety Code. And this refers to doors to hazardous areas, which means that on an annual basis, you need to inspect the fire doors in your organization and report your findings of that inspection in an annual report. By the way, we do have education available on our website for this annual requirement. You don't need to hire a company to do this. You can actually train people in your own organization to do it, assuming that they have gone through this training. 416.44C is the standard for building safety and states as follows. Except as otherwise provided in this section, the ASC must meet the applicable provisions and must proceed in accordance with the 2012 edition of the Healthcare Facilities Code, better known as NFPA 99. It does put some exceptions in here, and again, it's in the code. I'll provide a link to the code in the show notes. Continuing on to 416.44D, Standard for Emergency Equipment. The ASC medical staff and governing body of the ASC coordinates, develops, and revises ASC policies and procedures to specify the types of emergency equipment required for use in the ASC's operating room. The equipment must meet the following requirements. 1, be immediately available for use during emergency situations. 2, be appropriate for the facility's patient population. And 3, be maintained by appropriate personnel. Now, it's important to note here that CMS does not provide any specific guidelines with regard to the exact equipment that must be maintained to handle emergencies in a surgery center. But it does put the onus on the governing body and the medical staff to determine what is necessary to be able to handle any medical emergencies. And that's what you'll be evaluated against. Surveyors will look to, the governing body minutes, the medical staff minutes to see what the governing body and the medical staff has determined to be the appropriate or the required equipment in your surgery center. Continuing on to 416.44E, which is the standard for emergency personnel, and it states the following. Personnel trained in the use of emergency equipment and in cardiopulmonary resuscitation must be available whenever there is a patient in the ASC. So it's important to remember that you need to have CPR-trained individuals in the ASC at all times that a patient is there. Where this might come into play is if you have a receptionist that arrives before nurses and that receptionist does not have BLS training. Make sure all of your staff have at least BLS training. So during the Illinois State Association meeting in August, I had an opportunity to meet with my friend Ruben Garcia. He's a life safety surveyor with AAAHC, and he's also a life safety consultant. And he spoke during the association meeting about common life safety citations. I thought it would be useful to put that interview here. So let's listen to my discussion with Ruben about common life safety citations in an ASC. I'm here with Ruben Garcia. Ruben, you've been on the podcast at least once before, I think during ASCA 2024.
That's right.
We're here at the 2024 Illinois State Association meeting in Chicago, and you just finished a session on the Life Safety Code. Great job, by the way. So thank you so much for imparting your knowledge. Now, you're a surveyor, like I am, with AAAHC. You're a life safety surveyor. I'm a health surveyor.
Right.
Tell us a little bit about your background and what you do.
Yeah, so I... full-time, I'm a market director for facility management back in Houston for Common Spirit Health. So I manage about 5 hospitals there in the greater Houston area. And I also do consulting, independent consulting for ASCs and hospitals in regards to life safety. And then, of course, I'm also a life safety surveyor for AAAHC.
Right.
So that's my background there. And then I also got a device called the airflow checker and the gap checker that a friend of mine we're trying to push out and get out there, and so yeah, that's where I'm at.
You got a lot going on, and as a matter of fact, you work a little bit with our company too. We refer some of our business to you when we have a need, and I appreciate that.
Yeah.
So, Ruben, one of the things I think sometimes, especially new administrators or people that have never been through a survey before, are not always aware of is what is going to happen when that life safety surveyor shows up. Remember, they're only there every 3 years, so depending upon where you are in your cycle in life or cycle in your career, you might not know exactly what's going to happen. What kind of administrator, whoever is going to be walking around with the life safety surveyor, expect when he walks in the door?
Yeah, well, what you're going to expect is basically a tour of the building to ensure compliance with the life safety code. That's the gist of the whole life safety portion. Is the life safety code comes from just that. It's an NFPA standard called the life safety code, hence the term we use a lot, right? Because when I think of life safety, when I first got into it, I think of life safety in the context of like saving lives, like actual lives, right? More on the clinical side. But however, the life safety code is in the context of fire safety.
Right.
And that's what we're looking for. So the surveyor is going to be looking at the physical environment, the totality of the physical environment, and then they're going to review documentations that pertain to maintaining that physical environment for patient safety.
Right, and we do have to remind our audience that the Life Safety Code is a copyright of the National Fire Protection Association, the NFPA, and that comes out of NFPA 99 and 101.
That's correct.
So one big part of the conversation that you had with our audience today was what are some of the common things that you find that you end up having to cite during a life safety survey?
Sure. So some of the common deficiencies that I'm finding is issues with airflow, air pressure, and humidity. And so, it's the operating rooms that everybody maintains, and we all know they have to be positive pressure. It's I would say those less critical areas, such as your soil utility rooms, your clean supply, patient restrooms, those other rooms that are required to have a pressure differential that often seem to be going neglected. And so I've seen a lot of issues around that. As it pertains to humidity, I'm seeing a lot of the devices that they're using are not certified or calibrated devices. Mm-hmm. Other issues that I'm seeing is the dreaded unsealed penetrations.
Yeah.
I mean, it's like, everywhere we go, we see unsealed penetrations. That's another common deficiency. And I would say some lack of testing and inspection on the documentation side.
Yeah.
Those are probably my top 3 that I would say that I see when I'm surveying.
So from a documentation standpoint, what are the types of documents that the life safety surveyors are going to be looking at when they come into your surgery center?
So we're going to be looking at a lot of inspection and testing documentation as it pertains to your generator maintenance, your fire alarm maintenance, your sprinkler maintenance, your fire doors, eye wash stations. I mean, you name it. Anything that has to do with the physical environment, there's going to be some type of requirement to test and inspect.
But Ruben, I'm in a building. I'm in a medical office building, and the landlord takes care of the fire alarm and takes care of the sprinkler. I don't have to worry about that, right?
Oh man, that's an interesting point you say, because that's an interesting dynamic that a lot of ASCs run into. Is they have to deal with the landlord, who is the one in charge of doing a lot of this testing, right? And some of this testing that they do is compliant, but it's partially compliant because it doesn't check all the boxes. There's certain testing that has to occur Like, for example, you do the annual fire alarm test, but there's a semi-annual battery load test.
Right.
That seems to be a low-hanging fruit for a lot of ASCs, is because the landlord doesn't have that in their contract, right? So it comes to that. It's understanding what those requirements are. So that's some of the issues that we see there.
And of course, whatever your landlord doesn't do, you're going to have to do. I mean, I guess a good example of this. Let's say that I'm a tenant in a building, and I'm like, on the second floor and halfway down the corridor there, and the landlord doesn't do any testing of the emergency lights throughout the building. What is my responsibility going to be?
Well, your responsibility would be for your ASC at a minimum, and then the path to get out of the building.
Yeah.
So as you go down the stairwells and you go out to the public way, you're still liable to make sure that if your patients or your staff had to exit that pathway, that everything's going to be compliant.
Which, of course, means that you might end up, the surgery center might end up having to test the emergency lights in the building's stairways or in the ground floor, getting out to the exit.
That is correct, because it's technically outside of the ASC, but it's still within that path of egress, the means of egress. So that's a great point.
Now, not every surgery center is on multiple floors, but there are special rules, of course, special requirements with regard to elevators. What are you going to be looking for with regard to elevators?
When it comes to elevators, one of the documentations we're going to be looking for is a monthly testing of the firefighters' operations, or also known as the recall testing. And so that's one of the main components we'll be looking for. Also, making sure that you're following your local AHJ guidelines as it pertains to annual testing of the elevators. And then there's also a 5-year load testing, where they, have you ever seen the elevators where they say maximum capacity 2,000 pounds? Well, they have to test that every 5 years. They'll put some counterweights in there and actually ensure that it can meet that capacity.
It's kind of scary to me. Hopefully the elevator does make it. Otherwise, we have an interesting situation.
Or we change the capacity, right?
Yeah, right. I don't think I'd want to find out.
Right.
A big issue lately in a lot of surveys has been the issue of emergency electrical systems. And I know AAAHC has really been on top of this, really been keeping a very close eye on this at surgery centers. Can you talk about a little bit about what we're finding, especially with regard to organizations that might be doing deep sedation or general anesthesia?
Oh, definitely. Yeah, that's a major one for new ASCs. And so if you're doing the deep sedation, and then you have to have what's called a Type 1 electrical essential system. And basically what that means is you've got to have emergency power split into three distinct branches. One of them is the life safety branch, one of them is the critical branch, and one of them is the equipment branch. So critical, equipment, and life safety. And really the gist of it is there's only certain authorized circuits that can be on those branches. So for example, the life safety branch can only have exit signs, egress lighting, anything associated with the generator, the fire alarm power source, things of that nature. I can't just put a receptacle in Nurse Nancy's office, right? Or even other receptacles, because it's specific to life safety circuits. Conversely, for your critical branch, you're going to have all your red outlets, anything in task lighting, things associated with that, any refrigerators that are critical for medications and things of that nature. And then the equipment branch, I would say, is more of like an auxiliary circuit or branch. You can put other components that may not necessarily be on there, like, for example, your air handlers, things to keep the operations going if you did have a power outage.
It's almost like a miscellaneous
Correct,
thing.
yeah.
Yeah,
definitely.
like you decide you want to have all of your computers in a particular area on, for electricity. There's no requirement that you would have that, but certainly if you want to add that, that would be the branch you would put those on.
Exactly.
What do you find, though, when you go into a center, maybe an older center that doesn't have a Type 1 system, and yet they've told you that they're doing deep sedation or general anesthesia?
Yeah, that is a big issue, because you essentially change your operations, and means you would have to change your infrastructure of your electrical equipment, and that could be very costly. So that's a great point you bring up. So if they've changed it, they've essentially changed the type of status they should have, category of electrical essential equipment they should have. So that could be a major finding, because now they're, to your point, they've essentially went from a Type 2, which is less stringent, to a Type 1 that has more requirements.
Well, but to that point, you might have been you might have been doing those types of procedures. You might have been required to have a Type 1 system, but you, Ruben, walk in and you tell them for the first time that they have to have that type of system, and they say, well, Ruben, we've had these surveys for the last 20 years and nobody's told me this before. Oh
yeah, we get that all the time, and really a lot of it I can say is every surveyor is different. And not everything's checked, to be honest. I mean, everyone has a checklist, but those things happen often because, it's just it's just the nature of the beast, really.
Yeah, no, and that's important. I think one of the challenges that I have as a health surveyor, as we were kind of alluding to, is that I'll walk in and find something that they've been doing for years and years, and I'm the first one that discovered it. It actually just happened this week while I was doing a survey in Maryland, and nobody had ever brought it to their attention before, and I pointed out it's probably because I looked in a cabinet that probably nobody else looked in before. But to that point, we're surveyors, we're human. We have a lot to look at while we're out on site. We try to do the best job we can, yes. But we might not be looking in every single area. I mean, you run into that a lot, right?
Yeah, I mean, at the end of the day, it's a sample survey, right?
Yeah,
I mean,
that's a good point.
If I go and do the same survey as someone last week, we're going to traverse different areas of the building.
Yeah.
When it comes to looking above ceiling, I might pop this ceiling tile and look at this, particular wall. He may look at another particular wall. So it's all subjective when it comes to that.
Yeah, surveys would be a lot more expensive if we, and a lot longer if we had to look at absolutely everything that that needed to be done. So that's important. And I think you as our listeners out there just have to remember to not become complacent. As a matter of fact, I would actually go so far as to say if I had a perfect survey the last time, I'd be a little bit afraid this time.
Right.
Because as surveyors, right, when we see that, we're looking,
you're like,
for more.
Okay, no deficiencies. Let me see what I can find.
Right. Well, and what happened? Was it a surveyor that might not have been as experienced the last time around? Because it's just so rare. I'm sure you're like me. I've never walked out of a survey. Sorry, listeners that might be getting me as a surveyor soon. I've never walked out of a survey with no deficiencies, with zero findings.
Yeah, no, definitely.
So, well, I appreciate your time, Ruben. Thank you very much. We'll put your contact information into the show notes here. And as always, it's great talking to you.
I appreciate it, John. Thank you, sir.
Thanks.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
The Tennessee Ambulatory Surgery Center Association's annual conference will be September 12th and 13th in Chattanooga, Tennessee at the Chattanoogan.
The New York State Association of Ambulatory Surgery Centers annual conference is September 17th and 18th at the Desmond Hotel in Albany, New York. AHS will be doing the pre-conference, which is 3 hours of education, on Monday the 16th.
The Midwest ASC Association's annual conference is September 19th and 20th at the Lodge of the Four Seasons in Lake Ozark, Missouri.
The ASC-Central's virtual Infection Control 101 conference is September 26, 2024.
And the Infection Control 201 conference is Friday, September 27th, 2024. Now, we've been doing these valuable training programs since 2020. The programs have several purposes. They provide training to your infection control coordinators to meet the CMS conditions for coverage and the accreditation standards for infection control oversight training. And they also provide ongoing training, which is also required of these coordinators. And lastly, these programs do help prepare the coordinators for the CAPE certification. That's the Certified Ambulatory Infection Preventionist certification, if that's something they're interested in. So again, for more information about these conferences, visit ASC-Central.com.
The Atlantic States Conference, sponsored by the Virginia and North Carolina ASC Associations, is October 10th and 11th at the Embassy Suites by Hilton, Raleigh-Durham Research Triangle in Cary, North Carolina.
Our ASC-Central Virtual Director of Nursing Bootcamp is October 22nd to 25th, 2024. And for more information about that, visit ASC-Central.com.
The Becker's ASC 30th Annual Meeting, the Business and Operations of ASCs, is October 30th to November 2nd in Chicago, Illinois at the Hyatt Regency.
The Washington Ambulatory Surgery Association's 2024 Annual Education Conference and Trade Show will be November 7th through the 8th, 2024 at the Tulalip Resort and Spa in Tulalip, Washington. And I'll be speaking about accreditation and provide an update on accreditation trends, and we hope to do a special episode from there.
As we mentioned earlier, the 2024 Multi-State Conference is November 14th through the 16th, 2024, presented virtually. We will provide a link in our show notes for more information.
And ASCA 2025 Conference and Expo is April 30th through May 3rd, 2025 at the Gaylord Rockies Resort and Convention Center in Denver, Colorado. We're already making plans for that conference. Don't know if we're going to have a booth there yet, but more information to come. And don't forget, on-demand versions of the ASC Director of Nursing, ASC Administrators, and ASC Business Office Managers virtual boot camps are available on our sister website at ASC-Central.com. And a reminder to everyone to become a patron member of the podcast. Our program, which is available at ASC-Central.com, provides an exclusive membership website and a one-stop shop for all things ASC regulatory and accreditation compliance, operations, and financial management. It's perfect for busy administrators, nurse managers, and business office managers. With your membership, you get access to regular, usually weekly Zoom sessions where you can connect with other patron members and our podcast team. But that's not all. You also gain access to a treasure trove of resources, including our virtual conferences like the Credentialing Conference and the Conditions for Coverage Conference. Plus, we provide example policies and procedures, sample forms, and fire and disaster drill kits. Your membership helps to keep the podcast running smoothly by covering costs like research, travel, equipment, and production. For more details, visit ASC-Central.com.
Thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found this episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so you will never miss an episode. We'd also love any feedback about our episode or ideas for future episodes by sending us an email at comments@ascpodcast.com.
And we'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team of Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Kelleritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Fode, Donna Macchio, and Christina Norman. We certainly couldn't do it without them.
Our music is provided by Media Sushi and Mike Noah. And the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thank you for listening.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.